Thank you very much for this kind invitation, John. So I want to give an update regarding this trial because, and what you experienced today is actually that we do our best to learn from the previous studies. We have all the people around to learn from. And into this context, we also share what we see in our study. And I think it's one aspect which is very much important to us is that actually from the beginning we decided to go from Asia A to B and eventually C. Different reasons. One is to have more adequate readouts. You get better readouts regarding safety. You know that in Asia A patients you have some limited readouts. We will also have some more readouts regarding subtle changes, and what is also important is we think that in this kind of early trials, it needs to be a kind of a referral system because as you will see, you need to add very much knowledge and capacity in the center, and to make a phase 1 or phase 2 study being successful, you need to come to a meaningful size. So this is, as you would expect, a recognized clinical trial following all the regulations you can think about. And as we target in the first cohort Asia A patients, thoracic, you need to address the question, what is a meaningful, on one hand, safety outcome, and what can tell you something about potential effects? And if you go to classical readouts as used in all the other studies, if you take the SCIM scores, you will actually see this is a 1-year follow-up of patients, and these are sample sizes. This is a blue one of 300 patients, 60 patients A's, B's, and again 70 C's. If you would take the SCIM as a readout, you will be lost. No chance. No chance necessarily to see a harmful effect, and definitely no chance actually to see any kind of beneficial effect. If you look to the lower extremity motor scores, again, between the A's and B's, you can't see a difference. With the C's, obviously, you will see a difference. So it is very much important to have the appropriate appreciation what these clinical readouts provide you. And in our kind of appreciation, we think they might, for this approach, might be too less sensitive. So, as you know, we do a lot of these neurophysiological studies, again, with the question, what happens to the lesion size? We can map several pathways. And the question is, which of these measures we have, again, are appropriate for this trial? Not all measures are appropriate. So, not just talking about we apply neurophysiology, you need to target this appropriately. And one of the means is that we look in these patients, just think about, we talk about thoracic, Asia A patients, mid-thoracic lesion. In these patients, probably a segmental testing is where you might find some differences. And one of the ways to have the segmental testing are the dermatomal contact network potentials and the dermatomal SSCP. And again, the question is important, are they sensitive, are they specific? And in this case, you see a patient with an anterior spinal cord syndrome, where the anterior part is actually affected, and you do see a loss of these contact network potentials below the level of lesion, while the dorsal column represents like the dermatomal SCPs remain. So it's important. So you have a very distinct kind of readout, and not only to be specific to the pathways, you also need to have an understanding how sensitive these tests are actually. And we don't have yet sensitivity measures for recovery, but we definitely have sensitivity measures for mild impairment or mild contusions. And this is one of the examples we are following here in our hospital. We are looking for patients with a very mild signs of a chronic spinal cord lesion, the so-called snake eye syndrome in patients with a chronic compression. And in these patients, that typically show very unclear clinical findings. So typically the patients come with some numbness, less dexterity in the hands or whatever. It's a formal clinical examination. It's not really giving you a clear kind of deficit. And the question is, does the neurophysiological recordings help? And in this way, dermatomal SCP do not help really, but the contact network potentials, which again are assessing fibers crossing these central cord areas, they are very much sensitive. So this is also very much important to understand what the measure can potentially deliver. In these studies addressing these early trials in patients with a thoracic injury, and assuming that the most likelihood to see something might be sensory, you again need to address the question, how specific, how detailed will you be to address all the different dermatomes? And within the hand, this is a very different condition because these dermatomes are very distinct and very well circumscribed. And in the textbooks, this is also true for this body scheme. But as you know, reality is very much different, and it's very, very difficult actually to say where is what kind of level. And if you take different body shapes, we come up with an assumption that these areas, T2, T4, 7, and T10, these can be actually in all patients in a similar way being assessed. And so that is these are markers where we think you can actually identify this over time. And just also have in mind that in contrast to the textbooks, patients do not have this clear distinction between these levels. It's very difficult, really, if segments are so close to differentiate between T4, T5. This is less a problem if you look to these segments at the upper limb. So that's important. And doing these assessments in these patients, and this is true both for the dermatomal atopy as for the contactile work potentials, our assumption is that you can get reliable differences over time in these specific dermatomes. And in patients with this instrumentation, you can do these recordings in patients, and you will find in this case, T2 is normal, T4, T7 are somewhat impaired based on our control data. T10 is gone, so you get a very kind of a good understanding how the condition in this trunk dermatomes are. So I will just a little bit repeat comments from Raphael, which I think are important. So actually, to identify the cystic deformation is not that easy from the visualization. And as Raphael told you, that the ultrasound is very helpful. In my limited understanding, I'm not sure what this is, what that actually is. So I'm saying it's very difficult to say where is preserved cord, where is a perineural net or whatever. So I'm not sure if any living neuron is in this strip. I think that's a given problem. And in addition, as Raphael also alluded to, you might have additional small cavities here at the caudal on the rostral end, and actually the ultrasound-guided instrumentation or installation of cells might be actually very important. Based on these ultrasounds, then you actually can very specifically place your needles at the upper and lower edge of this cavity. So now I'll present some patient data and actually telling you about the difficulties or the challenges. In this patient here, you see repeated measures pre-surgically, and this is for the light touch. Then this represents several measures in the early days after injury. And then this is a measure in 6 months after this dosing of the cells. So what you see is actually that in this level here, you have a kind of an increase of this sensory level based on the definition like the Asia sensory scores are taken. And in this instance, the patient reported not of any kind of loss of sensation, but he experienced that the sensation was kind of more crystal, more close, more vivid. But based on the classification, on the standards, this becomes scored as an impaired because it's changed to the normal. And you know, change to the normal can be anything. It can be kind of reduction loss. It can be an increased sensation, it could be a painful sensation, it could be an allodynia. So it's very much important to now to think about, okay, here is a change, not an early change, a delayed change, what it does mean. So if we apply these contact heat evoked potentials, you see how these recordings are looking before the surgery. So these are repeated recordings, specifically in the segment T7 on the left side. This marks the surgery, and after surgery, you can see by yourself that actually these recordings are actually preserved. There's no change in these recordings. And if you look also to amplitude, so this is just overlaid, actually the amplitudes stay normal and are actually not changed. So in this segment, these assessments are actually not changed. You can also take kind of thermal thresholds, a thermal sensation that you actually perceive the sensation, or if the level of pain, the pain threshold. So in the last normal segment of the patient, all these pain thresholds and all these sensory thresholds are actually not changed throughout. So again, here before surgery, and this is the long-term follow-up. So while looking to one segment, it's very complicated. Now in this picture, you can actually see all the segments. What you do see is here the heat perception. Can the patient perceive heat? You do see that here the patient has an impaired sensation based on the thermal thresholds, and over time actually this improved. So the patient reported this kind of increased sensation, no painful sensation, but more crystal, more clear sensation. And if you look to the heat perception thresholds, you do see that it's changing, that this is actually improving. And now look here to the level T10. So this is the level T10. You do see that at the last examination, so 6 months out, not early, in a later stage, in this segment where he had a highly impaired sensation for heat, he actually improved this kind of sensation for the perception of a thermal stimulation, and actually also the pain threshold became actually measurable. So he had no pain before with high stimulation, and then he experienced again some pain. So just to show what the clinical kind of classification would tell you and what some of the detailed measurements tell you. The same we did in this patient with electrical perception threshold measures. These measures are very difficult really to understand what they tell, but they probably are conveyed through the dorsal column. There's evidence for this. The advantage of these measures, if you put a probe onto the skin and you start to play with the engine, and the patient is actually not able to relate any action. That's a very different condition as if you stroke above the skin. The patient always gets a feeling, or he should sense something or not. In this condition, no, because the probe is on the skin, attached, and he has no cue to have an idea if he should feel something or whatever. So in this instant, again, you see here the segment here being reduced. So it's not normal. The threshold is slightly increased. Here, the threshold is very much increased and even absent. And in the long-term follow-up, actually, this became normalized. And here, the sensation actually improved. So this is the same patient. So in the other patient, again, this with the instrumentation, the patient has a cystic formation, and this is the post-surgical MRI. We saw a kind of another change, a very dramatic change. So this is a patient here with a very clear sensory level. T4 is, T6 is lost. So T6 is lost 1 month after injury, and at the last visit, the patient reports to have sensation here. So this is a very extended area where the patient reports to have gained some sensation. So again, in this patient, going by the segments, you do see that he has this lost sensation at the T7 and T10. So with high electrical stimulation up to 40 milliamps, he is not sensing anything. And actually in this follow-up examination 3 months later, he gets an improvement. He starts to sense sensation, and here actually very much improves the quality of the sensation. So you find a concordant finding between your clinical testing that there is a change, and this actually becomes confirmed with this kind of electrical perception measures. So when looking at some of the clinical measures, so John Steeves showed you in the morning session that sensory changes at the thoracic trunk are very minor. So that you get a segmental improvement more than 2 segments by sensory testing in a thoracic Asia A patient is a very infrequent finding. We, in addition, did a study together with the EMSCI group applying these electrical perception thresholds in 37 patients with spinal cord injury and in 10 patients with a spinal thoracic Asia A condition, so like the patients we tested here. And this patient had been assessed at 3 times up to 6 months. And if you look to these patients, you do see that actually there's almost no change in the electrical perception measures. So typically, in the first segment above the lesion site, the recordings are normal. There's a slight impairment at the level of lesion. And 1 segment, 2 or 5 segments below, as you would expect, the EPTs are severely affected. And in the long-term follow-up, 1 month, 3 and 6 months, you don't see typically in these patients a recovery. So this is a kind of historical data to give an impression how responsive during time these EPTs are. And if you contrast then the findings in our patient, in the last one I showed you, you do see that this patient in this T10, T7 segment showed a very much increased change of these thresholds. So this is the 3rd patient, and he's actually having had this pre-surgically, 1 day post-surgery, 6 months follow-up, and he's not changing anything. So the intention to bring this kind of 3 different cases, and we don't have more, so these 3 cases, is actually so you can see changes, and the question is which of the changes would be just random or would be a variability, or is there a kind of a true change in these patients' conditions, what you might relate to the surgery and the treatment. I think we don't know yet, but we are very confident actually that the measurements in these patients can be done very reliably as a readout. And we think that it's very much important, as I showed you in the first case, that in addition to the ASIA standards, you need to add an additional measurement, and probably several, to really make sure what the changes you see with the ASIA assessments might actually mean. So this is the sum up. So we dosed the first cohort of the 3 Asia A patients. I think we have a good reason to state that the short-term and eventually mid-term safety looks favorable. So in all our adverse events list, there was no kind of issue which we could attribute to the surgery or either delayed to potentially effects of the implanted cells. And at this stage, we very carefully state that we do see secondary changes which are not related to the immediate surgery, but actually are appearing with some delay after the intervention, which could reflect some kind of activity of the intervention. So we are now actually interested to go to the next cohort, to the Asia B patients and C patients, and will actually, of course, apply the similar setup. And in these patients, however, then in addition, the longitudinal pathways come also into play. So in the B patients, we are obviously should be able, or to some extent could be able, to also measure the longitudinal tibial and pudendal SAPs, and again with the same kind of context to provide an additional readout to inform the clinical findings. And in the patients now, we have concluded this contract that we will do a long-term follow-up of the patients up to 5 years. So thank you very much for your attention.
Thank you for a very informative talk. I have a couple of questions in terms of what your thinking is in terms of further refining the concept of neurophysiologic measures in these thoracic patients. One is, it seemed as though your ability to produce a higher resolution impression of patient of these physiological outcomes was somewhat hampered by choosing only discretely the T4, T7, T10. In some of these patients, some of the 3 patient graphics that you showed, I just wished that you had had a higher resolution readout. Have you thought about that? So that's question number 1, of adding the interim dermatomes. And I understand the reluctance based on body habitus differences and that sort of thing, but it would have been nice to have a higher resolution, if you will, of the segmental progression or improvement in those patients without having to rely on this gap between the dermatomes you're testing. Number 2, it's also would have been interesting to look at motor evoked potentials, which some have attempted, and I don't know what your experience with that is in terms of paraspinal motor evokes. And also, you only told us about what the patient reported in the first case. You didn't tell us what the patient reported in the other 2. Were they reporting any subjective correlates to these changes that you saw in the electrical and heat contact thresholds?
So I think you're a typical scientist. You're never satisfied. So you might have a chat with my technicians regarding adding several segments. So these testings are not difficult, whatever, but they're time-consuming and whatever, so it's not easy. And also in the equation of the importance of the relevance of the changes, I actually believe if you don't get a sensory changing more than in 2 segments, whatever, it's likely not dramatic, whatever. So having this kind of levels and finding changes then in these levels, that might be already something across a threshold. We would, in the upper limbs, we would go segment by segment. But I think in the trunk dermatomes, I would be afraid to have not really conclusive readouts and a too high variability. So having this apart segments might be actually a kind of an advantage. And the same is actually true for the motor evoked potentials from trunk muscles. There's such a huge overlay in the muscles that I'm not aware about a reliable technique really going segment by segment. So that's the reason we did not apply it. I think that was 2 main questions.
Well, the other question was the patient reported out.
Oh yeah, sorry. Yeah.
I think you said that the first patient was not aware of any functionally significant change. They hadn't noticed the change. But the other 2, especially that second patient who had such an incredible
I have to
lengthening of his transition zone, what did he tell you?
No, actually, all the patients reported self-experienced changes, which have been related to what we have been showing. So this patient with the huge change, he came and told, you know what, I can sense here, I can there, whatever. And also with the other patient, having this kind of more clear, more intense sensation. And I have to state that in all the patients, we do kind of pain questionnaires, 2 different kinds of, And none of the, in none of the patients we had a kind of a pain problem, allodynia, hyperesthesia. There was no change in this direction, because that was one of the fears, of course, by this one patient saying, you know, it becomes intense, whatever. But that was not the case.
One of the concerns, obviously, is that to get something to be accepted clinically, you have to have at least some signal that you can reliably say is functionally significant to the patient. All of our concerns about the in-stream sensory testing is that it's a very low sensitivity, and that there's probably a continuum of impaired but functional to very impaired and not terribly functional, but maybe sorted out by some reasonable potential. My interpretation of what you told us is that this is perhaps better than the sensory, the crude sensory that we have, and it may be an indication of protective sensation that is important.
I actually would think that you have met already the second and third step. At this stage, it's all about safety, as you know, and is there a feasible way to find a true change, an effectiveness of the intervention? That's it. We are not at the point to say it's good or it's clinically meaningful. That's not the point here, right?
Armin, recruitment, thoracic Asia Bs, thoracic Asia Cs, they're not that common.
Yep.
Is there a contingency plan here for handling or changing the protocols to handle the low incidence of thoracic Asia Bs, thoracic Cs?
There's always a caveat to a very good idea, right? So go from Asia A immediately to B is a good idea. But in the interest really to come a step further, I think it is fundamental important to go to incomplete.
Yes, but
so and the problem is, to some extent, is the, of course, lower number of Bs. So the numbers for the B patients, and you have been pulled them very nicely together, are about 10 to 15% of a traumatic cohort. These are the thoracic Bs and Cs, it's 15%. And I think this is also a very special group, and therefore I think the setup of this referral system is also, again, very important. And it needs to be understood that that Bs are a very important and very appropriate group to study, and that such a study needs to be done in a well-experienced setup.
One question, I mean, the first patient, I mean, showed some improvement in some measurements, but also impairment whatsoever. Of course, there is concern that it might be due to syrinx formation or due to tumor formation. I'm just wondering, with all the dorsal instrumentation, I mean, in the previous presentation we heard that there have been some new sequences started with MRI. Do you think the MRI, the follow-up MRI, is sensitive enough to really detect also minor changes, meaning increased syrinx or tumor formation?
So one of the inclusion criteria has been that we could visualize the cyst or the lesion area to some extent. You don't get brilliant pictures, but you should have an idea where the lesion size is. And only to this extent we can follow up. And we do. So we have regular follow-up MRIs with the question really. So what is the cyst about? Is this changing? And also in the acute MRIs we do just with the interest, do we induce some kind of bleed, which we would not recognize in an Asia A patient. So, but it's to some extent limited, I think.